Shall we start? Let me just start by thanking all of us who have joined this webinar. My name is Bernard Musako. I'm a Tekano Fellow under the Atlantic Fellowship for Health Equity in South Africa. I'm also a health policy researcher. I'm working for one of the biggest health companies in South Africa. And I love health equity. I love primary health care. So let me just start by thanking all of us for joining for this first webinar on NHI. Let me also appreciate our speakers, our two speakers who have joined us and are ready to share with us. So by way of introduction, we know that the NHI bill was passed by the NCOP on 6 December last year, and most likely it is going to be signed into law. Signs are high that it is going to become law. And so it's going to happen that one day we'll wake up with NHI on our doorstep, and we need to understand how it works, how it's going to affect us, how it's going to affect every South African. So yeah, we really need to unpack the NHI, understand what is in the bill, how it is going to work, how it's going to be funded, how it's structured, the timelines, and most importantly for us as fellows, how it's going to affect health equity. So a number of us fellows express that they do not understand NHI, and you'll be surprised at the level of ignorance about NHI that is in the country and even among healthcare professionals. So as fellows, we expressed an interest to understand more about NHI amongst ourselves, and we approached Tekano, who has agreed to fund this engagement. So today's engagement is the first of a series. We are going to be understanding the basics of NHI, and we have an interesting lineup of speakers. I'd like to thank Tekano for funding this engagement. This is an engagement that is organized by us fellows collectively. So let us sit back and relax and engage. And we do also welcome some people who are here who are not Tekano fellows. Thank you, and over to you, Tinashe, our facilitator.
Okay, thank you and greetings all, and would like to welcome you to our inaugural NHI series. As Bernard said, this series of webinars are being put together by a group of fellows. They are there to help us understand the NHI, the bill that is currently on President's desk. The National Health Insurance has been the subject of intense controversy in the past few weeks. As fellows, we believe that it is important for us to be on the same page in knowing and understanding the newly proposed bill, which will know that it will alter our health system. So today we are joined by two speakers who will go over on what is NHI, examining the bill in more detail and attempting to comprehend its impact to everyone, as well as highlighting the sources of fund. So today we are being joined by two speakers who are Russell Rassenberg. Comrade Russell Rassenberg is a health activist working towards health equitable access to quality healthcare for rural communities and serves as the current director of Rural Health Advocacy Project. Comrade Russell has got over 15 years experience of working on strengthening health system, with 8 of those he spent in managing technical assistance in the Eastern Cape in South Africa. And then our second speaker is going to be Comrade Yvette. Comrade Yvette is a part of us. So she's a part of us. She's a community health activist and a public servant. She's particularly interested in how health system can be used to create equitable pathways for the healthcare for the marginalized and vulnerable people who are usually excluded in decision making. So those are our two speakers that are going to help us unpack today's seminar. As I've mentioned, there are going to be more seminars that are going to come in future. So over to you, Comrade Russell. You got 15 minutes. I know it's quite a broad topic, and we would like you to cover as much as you can in the limited time that we have. And those who have got comments, that they want to share or questions that they want to ask, please feel free to put them in the chat box. Thank you so much.
Hi, Russell, you're muted.
Yes.
Hey, there we go. 3 years after the pandemic, and I'm still struggling with the mute button. Firstly, good afternoon, fellows, and I hope your fellowship journey is still continuing well and you continue to grow. And we're looking forward to you, all of you, activating that leadership in this massive reform of our health system. So the NHI for me is really about enabling the realization of the right to healthcare, which many of us refer to and is stated in our constitution under section 27 of the Bill of Rights. So I've titled the presentation, Enabling the Realization of the Right to Healthcare. You know, as you know, I'd like to start off this with a quote that came out of the World Health Report, which was an alternative World Health Report published by the People's Health Movement. And I think it kind of captures so much about healthcare that often gets lost in the debate. Often when we talk about healthcare, we tend to focus more on what we understand around care, which is really responses to disease. But health really transcends the entire spectrum of existing social movements and is indeed feeding a diverse set of struggles. Health is what brings together various movements with a shared claim. Health injustices are making a powerful call to mobilize. Now, if we pause here for a moment and we start thinking about how health intersects with everything, right? And access to healthcare is one of the enablers of human development. You know, Olaf Palmer, when asked what makes him a social democrat, he said that everybody should have access to a decent life. And a decent life is access to healthcare when you need it. It's access to a job, ideally, which is not included in our constitution, but in my view should be. It's access to education. And lastly is access to social assistance if you need it. And health is almost a kind of social assistance as well, right? And I think it's only through the realization of these rights or entitlements that we really can achieve freedom insofar as that we can direct the course of our own lives. Now, the South African Constitution recognizes this, right? And in section 27, where it guarantees everybody the right to access healthcare services, including reproductive health. And then linked to that, we have the National Health Act, which is the framework through which healthcare services must be provided in light of its constitutional obligations. You'll see that this particular version of the picture here was edited by Adila Hassan, which many of us will now know is also our lead advocate in the case at the International Criminal Court, which looked at investigating the charges of genocide. So really, health has really given life to a lot of different activists, and it's a continued struggle that we work on. So, like I said, I think the right to health in South Africa, everyone has access to healthcare services, including reproductive health, sufficient food and water, social security, including, if they're unable to support themselves and their dependents, appropriate social assistance. Focus of the NHI obviously fits more in line with Section 1A of Section 27, which deals specifically with healthcare services. And you'll note that healthcare are two separate words, including reproductive and reproductive healthcare. Under the Bill of Rights, the state has an obligation to take legislative, which means the creation of new laws and etc., and other measures within its available resources to achieve the progressive realization of these rights, and in this instance, the progressive realization of the right to health. Some of you may be familiar with a publication called the District Health Barometer, which comes out annually, but hasn't come out since 2020. And what it does is it sort of tracks our performance on essential health services across the 52 districts. Included in those essential health services are things like sexual and reproductive health care, right? Maternal and child health, maternal and child health, responses to infectious diseases, and responses to non-communicable diseases like hypertension, obesity, diabetes, interpersonal injury. And And I think I'm mentioning interpersonal injury because in preparation for this talk, I sort of looked at our performance across the number of districts. And what was interesting, given Tekano's youth focus, is that the leading cause of death amongst young men across most districts is interpersonal violence. And that interpersonal violence could indicate a number of different health inefficiencies. Firstly, I think some of the things that we don't know is the responsiveness of the health system to injury. How quickly do ambulances get to places where people get injured? Road accidents like the horrendous one we saw outside Mthatha, and the extent to which emergency medical services could have avoided loss of life. And I think and it also highlights the importance of a much broader set of health data and organization to improve broader access to healthcare services. So what is the national health insurance? Look, I suppose this is the billion-dollar question, or the $265 billion question. What is the national health insurance? So firstly, the national health insurance doesn't replace the National Health Act, which remains the primary piece of legislation that organizes the coordination and the regulation of the South African health system. What the national health insurance is a health financing system that is designed to pool funds together to provide access to quality and affordable personal health services to all South Africans based on their health needs, irrespective of their socioeconomic status. It is a fund that will pay for healthcare for all South Africans. There will be no fees at the health facility because the NHI fund will cover the cost of care. But like most things, it's a progressive and phased implementation, which is likely to take a number of different years or several decades, depending on how quickly we can get this, and dependent on the quality of our advocacy and activism in ensuring that our political accountability sees this as a primary responsibility. In the short term, the focus will be on primary or district health services. And I think that is where 80% of the population, or 80% and 90% of the health needs can be met. So Section 22 or 32 really just talks about what are some of the immediate things that may happen, right? As many of you know, health is a concurrent responsibility between national and provincial governments, where with the national government being responsible for health policy and the coordination of the health system. Under the Act or under the bill, in Section 32 of the bill in particular, the minister will propose amendments to the National Health Act for the purpose of centralizing funding of healthcare services as is required by this Act. And in such cases, the minister may delegate to provinces as management agents for the purposes of provision of healthcare services, and in those cases that the fund must contract with within the province, such as provincial, tertiary, regional, and emergency medical services. Right? So I think in the first instance, to give some substance to that, currently when we fund healthcare, we fund it from nationally raised revenue, right? Money is allocated to the National Department of Health and to provincial departments of health, which are the principal deliverer of services, right? There's no standardized package of care that is delivered across all 9 different provinces. And part of that sits with the minister, who hasn't declared the quantum of essential healthcare services or what primary healthcare services should include. So there's really no guidance from national to provinces on what kind of services should be offered. And the result is that South Africans, often the quality of healthcare services that South Africans receive is often an accident of birth, where they were born, which province they were born, which district they were born. And I think that kind of goes against what the goals of the right to healthcare was, and it delays the progressive realization of that right. Similarly, as part of our transition from the previous order, we also inherited a very comprehensive health system that at that point was servicing the needs of, let's say, 20 to 25% of the population. And even within the National Health Act, we haven't got a clear sense on what we should be doing with these assets, or how equitable the services that are delivered at tertiary and regional hospitals at the moment, and most of them are funded in a very amorphous kind of way. And I think what the bill or the Act may introduce is dedicated funding for hospitals that is based on DRGs or diagnostic-related groups, and will provide a better opportunity for making these assets a lot more effective. But the main focus of the NHI in the short term is the establishment of stronger district health services, which will be coordinated by district management offices, which currently sit within provinces, but under this act may move to become national offices. How will it be funded? Well, I think this is one of the things that a lot of the proponents of the bill talk about. You can't really say what the NHI will cost until you've quantified the services, right? And I think those services are the subject of the Benefits Advisory Committee. But as it stands, in the near term, the NHI will be funded from existing health allocations, from nationally collected revenue. No new taxes are proposed in the short term. Right. And as I indicated, health is currently a shared competence between national and provincial departments of health. So under Section 32 of the fund, of the Act at the moment, they're looking at consolidating all of this funding, that's equitable share funding, provincial equitable share funding, conditional grants, into a single fund for strategic purchasing for healthcare services for the public sector. Right. In future, there is a proposal to raise additional funding through the levying of a payroll tax, which is not dissimilar to some of the setups in Australia, New Zealand, and most notably in the National Health Service in the United Kingdom, where you pay an additional charge in addition to the taxes that you generally pay as a levy for the NHS. So I think South Africa is considering similar things. So on the funding in the longer term, we may get a clearer picture, but based on what we have at the moment, during the interim measures, it will focus primarily on the funds that we already raised. The short-term proposal is that we may introduce a payroll tax, and that payroll tax could be anything from 1 to 3% of the payroll, which is very similar to what we're currently paying for training or training levies, but can contribute to additional funding for the publicly funded system. So what is the objective of the fund? Obviously, the objective of the fund is to achieve universal health coverage, as described in SDG 3 of the Sustainable Development Goals. But in the longer term, the purpose of this bill or act is to maintain a national health insurance fund that is funded through mandatory prepayment that aims to achieve sustainable and affordable universal access to quality healthcare services by creating a mechanism for a single purchaser and single payer of healthcare services, to ensure that funds are equitably and fairly distributed across all healthcare services, ensuring the sustainability of the funding for healthcare services with the Republic, better information and better decision-making, and lastly, providing for equity and efficiency in the pooling of funds and strategic purchases of healthcare services, medicines, health goods, and related products. In relation to Section C, I think one of the things that guides us are the opportunities of saving additional money and improving the effectiveness was, for instance, the introduction in the 2010 of the transversal tender for ARVs, which led to the significant decrease in the cost per patient for HIV services, and in part contributed to moving us from an HIV emergency to a space where we have a much more sustainable HIV response, with close to 6 million people currently on treatment, right? With over 90, which represents close to 90% of people, according to the HSRC, of people who know their HIV status and have access to treatment. Access to treatment is sitting at least, people on treatment is sitting at least 80%. And more importantly, more than 95% of those on treatment are currently virus suppressed, meaning that the HIV virus is both undetectable and untransmissible, and in many ways leading to ending HIV as a public health threat. So some of these opportunities can be translated in expanding access to other services, like maternal and child health services, particularly child services, as well as a better response to the biggest scourge that we're facing as health systems, which is non-communicable diseases. So what does this mean for the layperson? Like I thought about this for a little bit, and again, I don't have all the answers, but what I can say is, in the short term, the creation of contracting units for primary healthcare organized around district hospitals decentralizes a lot of these essential services. in one of a publication from Candy Gray and others, sort of looked at access to essential healthcare services using what they call a UHC index. And they found across the country or across provinces, the country was sitting sort of at 67% on on coverage on these essential services, which I list here. The coverage is fairly high, but it's not consistent across all districts. And generally, rural districts, as well as some of those urban sub-districts, have significantly lower coverage across essential health services. And one of the opportunities that's presented by this decentralization to sub-districts is to allow for more proactive responses to local health priorities, increased accountability at the local level where our targets are set and overseen by our army of health activists, which we've grown, and can improve responsiveness of the system at the local level and lead to improved population health outcomes over the longer term. Similarly, we also need to figure out how our healthcare services are more responsive to the working poor. As healthcare services are currently structured, they actually don't need to meet the needs of low-income workers. And a recent study from the Bureau of Marketing Research at UNISA, for instance, found that 75% of working South Africans earn less than 6,000 Rand per month, meaning that purchasing additional healthcare is almost impossible. But also accessing healthcare services can be incredibly hard, as clinics are not geared to deal with routine health issues. And in many ways, have really just become areas where we seek maternal and child health services and the responses to chronic diseases. Currently, Section 37 allows for the introduction of private providers in organized horizontal networks within a specified geographical area. What this means is that we can contract in private general practitioners, rehab professionals like physiotherapists, occupational therapists, and so forth, as well as other things like optometrists, which is currently very, very difficult to access in the public service. By making these things available within a package of care district health services, we can improve the responsiveness of the healthcare services to the working population, as well as to the youth, entrepreneurs, and so on, who currently cannot afford to hold these services. We'll remember, for instance, that instance at Tembisa Hospital early in the COVID pandemic, where a very well-known gig worker or media worker, right, was admitted to hospital, right, was very frustrated in a public hospital, but didn't have medical aid. And the result was that difficult interaction with public health services and expectations and the treatment given by the health system contributed to a death which in my opinion could have been avoided. But we need to, and this is an opportunity for us over the longer term to improve the responsiveness of the health service, not just to essential health services, but also to the general needs of growing entrepreneurs, the youth, and the working population, something that it currently doesn't do, and something that the current medical scheme environment doesn't support, because even the lowest packages can cost anything from 1,000 to 2,000 per patient, making it incredibly unaffordable. So my last slide in terms of equity, South Africa is one of the most unequal societies in the world, and it will remain so, right? Unless we make deliberate attempts to address the impact on inequality on the health of the population, a national priority, right? Even economic growth will not, without some kind of social safety net, will not contribute to the system determinants or the societal determinants of health, including, but access to healthcare services that is of sufficient quality and responsive to the needs can contribute or mitigate the impact of living in an unequal society and create a platform for us to fully participate in our own development and direction. The initial focus on district health services is also an important first step, because if it's well implemented, it can radically improve the responsiveness of the health system to the needs of the majority of the population who currently sit outside organized healthcare. If you're not ill, you're not going to access the state's primary healthcare system in the way it's currently structured. By improving the effectiveness of our hospital network, where the introduction of dedicated budgets can act as a catalyst for improved use of data in healthcare provision. That improved use of data will allow us to fill knowledge gaps on access for the 80% to elective surgeries where they're underrepresented, for example, like hip replacements, cancer care. We don't routinely screen for cancer in our primary healthcare system, and having better access to understanding what's happening within our larger hospitals, we can have a better sense of who's currently benefiting from care, who's left behind, and what measures we should be taking to improve broader access to healthcare services, not just a few. And there's a host of other maladies or diseases that at the moment we don't have insight into. And I think one of the maxims that sort of quantify this is something that they call the inverse care law, which was developed by Tudor Hill. And what that talks about is that the people that often need the most care are the least likely to access it. We saw, for instance, my closing remark, that the official deaths for COVID was just over 109,000 over the 3 years or 2 and a bit years of the pandemic. Yet, excess deaths over the same period was almost 3 times as much, at over 320,000 deaths. And even if just 80% of those people, right, possibly lost their lives to not accessing COVID care, that is already a significant indicator of how inequity to health access contributes to weaker population outcomes, particularly for the previously disadvantaged. Thank you very much for your attention. I hope I was able to stay broadly within the 15 minutes, and I'm looking forward to the questions and answers, which maybe we can add a little bit more substance or direction to some of the questions that you may have. Thank you, and over.
Thank you, Comrade Russell. It's very mouthful. Without wasting much time, we are going to, there are already 2 questions in the chat box. So if we can think of how you're going to answer them in the question and answer box. So without wasting much time, we're going to give the chance to our colleague Yvette, whom I've already introduced. Without wasting much time, Comrade Yvette, it's now, your turn is now. You've got 15 minutes. Thank you.
Hi, good afternoon, everybody. I hope you can see me. Although if, Russell, you could stop sharing your screen, I think that might make it easier for people to see me. As Russell said, my name is Yvette Andrews, and I'm a Takano Health Fellow, and I have a particular interest in community health and how the NHI will impact community health workers and health workers working on the ground with some of the communities that Russell was alluding to in his presentation. I have been asked to partly respond to Russell, but also to give the fellows' perspective on how NHI will impact us as South Africans, but us as sort of health systems conscious people. So as we heard, NHI in its current state, in its current bill, is a health financing tool, and the National Department of Health will pool the funds to provide access to quality, affordable health services for all. It would allow, ideally, it would allow for people to be able to access healthcare based on their healthcare needs, not based on what they can afford to pay. And I think that's something that all of us would want, and particularly those of us working in the healthcare field, the idea that our health services or our accessibility to healthcare would be based on what our health needs are versus how much we could pay at any one given time. However, we also know that in order for this to happen, you need to have a functioning health system that is able to provide good quality care at any one point, because it's great to have a health system on paper that's going to provide equitable and good quality health care, but then on the ground, due to financial constraints, budget cuts, etc., they're unable to provide such healthcare. So NHI will address the health needs of South Africans based on their illnesses rather than being irrespective of their socioeconomic status. It's not a NHI is not a medical scheme. It will be a transformation, and a radical transformation at that, of the South African health system as we know it. And it would be a way of sharing the existing health budget amongst everybody within South Africa, rather than the way that it is currently, where we have a two-tiered health system. And that brings me to the next point, which is the funding and the implementation of NHI. The idea of NHI would be to have a collective funding pool, and it would be a pooling of all the budgets pertaining to healthcare. And it would ensure that no one may be refused emergency care. So we all know horrific stories of people who've required emergency care, and when an ambulance arrives, the first question that is asked is not what is your health need, but where is your medical aid card, or can you pay X amount of money up front? And for some people, as Russell mentioned, it may be even as much as their entire monthly income to access that healthcare. So NHI aims to address that, and it aims to prevent that from happening. Currently, we have a two-tiered system. So we have the public healthcare system, which caters to approximately 84% of our population. And then we have a private healthcare system, which currently caters to about 16% of our population. However, the majority of the specialists, the healthcare professionals, are working within the private healthcare system, which only caters for 16% of the population. So currently 8 out of 10 South Africans are dependent on our public healthcare system, whilst the majority of the healthcare workers are serving the 16% of the population who can afford a private medical aid. And NHI is hoping to address that. The amount spent currently on a person with medical aid is about 5 times more than what we spend on a person who's dependent on the public healthcare system. And yet we've kind of accepted that this two-tiered system is the way healthcare just happens to be within South Africa. And NHI provides us with an alternative to the way we do healthcare. And I mean, as we've heard from Russell, that NHI will improve access to health services. It will allow for affordable healthcare for all South Africans, irrespective of their socioeconomic status. It would be a system in which your health needs determine which service you get. It would be a more equitable system, which would uphold the Constitution, and it would be a fairer distribution of the health services and the improved quality of care. I think my concerns as a public healthcare worker working on the ground is how NHI is going to be practically implemented, because as yet we have not seen much around the practical implementation of NHI. And there are structural issues which remain within the current health system, which are not miraculously going to be solved by the implementation of NHI. And in fact, the implementation of the NHI Bill in its current form may further exacerbate some of those structural issues. Currently, the bill speaks to changing the way in which money is spent without addressing the challenges which we are currently faced with in the health system. I think that the issue of universal health coverage is not up for debate, but it's how we go about implementing that, how we go about implementing NHI in a way which allows it to be practically feasible. Because unfortunately, as we know, in South Africa, we often have wonderful policies and programs on paper, but when it comes to practical implementation, this often doesn't filter down to the ground, and it doesn't allow for the practical realization of what the policy had initially intended. I was also asked to speak about what NHI could mean for the local person on the ground, and I think for me, this is part of my passion and part of what drew me to my involvement in Takano, because as I said, I work for a provincial Department of Health in the Western Cape, and a part of my role is to work with community healthcare workers. And the role of community healthcare workers in the Western Cape is to provide a kind of community-based response to healthcare needs of a defined geographic community. Within the Western Cape, we're really looking at including wellness within the concept of healthcare, and really looking towards achieving community-orientated primary care, which allows for the needs of the community to sort of support or encourage the services that are rendered within a community. We do have a lot of work around responding to the needs of the community and to improve like equity of health services. However, the things that hamper service delivery where I work is the high staff turnover, the shortage of staff, the budget constraints which exist within the public healthcare system, the high levels of burnout amongst healthcare workers, the fact that we are a health system which has faced huge changes and sort of impacts or knocks on the health system. So if you, as you everybody would know, during COVID, we had a complete transformation of how services were delivered in some extent. And then before fully recovering from that, we had the national rollout of the COVID vaccine. And then it was back to the recovery of the NHI, recovery of the health system. And so many healthcare workers, many community health workers are feeling quite burnt out and fatigued from all the change that they've had to face with. And unfortunately, this has led to problems within the current health system, and it's led to problems like an increase in TB figures. We're seeing diseases which previously we had better control of, now sort of almost becoming out of control due to the fact that we are struggling with all the demands that are placed on an overburdened health system. And the concern is that the implementation of NHI may worsen the situation rather than the good that was intended. And I believe that universal health coverage, I believe that the implementation of NHI is definitely something that we as fellows, we should support. And just recently, I was privileged to be working with a group of community health workers in the CBD, whose primary focus is to provide basic primary health care to street-based people or people living on the streets who do not access our healthcare system because they feel that it's not accessible system for them. It's a system that they feel is exclusionary of people who live on the streets. And by being able to take the healthcare service to the people on the streets rather than expecting the people on the streets to come to the healthcare service, we were able to support and generate a space which was far more affirming and respectful and enabled street-based people to feel that they can ask the questions that they have of healthcare workers, that they were able to express their concerns about their particular health conditions due to their living conditions. And we were able to find ways in which we could meet their healthcare needs without expecting them to conform to the normal processes to be found within a day hospital. It was one which took into account their fears of the sort of structured health system. And my hope is that NHI will allow for more of that kind of thing. As Russell said, that NHI, if implemented correctly and properly, would allow for people, the poorest of the poor, the voiceless, the people who most need our healthcare system, to be able to express their opinions about what would work for them. And for us to be able to create a system within NHI that allows everybody to access the healthcare they need when they need it, and that the care would be delivered by healthcare workers who are passionate about the work that they do and are able to really respond to the individual that is in front of them. And I see Tinashe said I have 2 minutes left. So I really want to say that I believe that NHI is a wonderful opportunity for us to transform our health system into something which is equitable, something which it allows for access to healthcare for every South African, regardless of their socioeconomic status. However, I just want to note that my concern as a healthcare worker is that the way in which NHI is implemented will definitely see whether it becomes a success or a failure. And so although the idea of NHI is great, we need to ensure that the implementation of NHI is done in a way in which our dreams of an equitable health system is realized, rather than it being a great policy on paper, but it never gets implemented in that way on the ground where it's needed the most. Thank you very much.
Thank you so much. Thank you so much, Yvette. I mean, you touched on one of the areas that is at my heart. You know, CHWs are doing quite a lot of work in poor communities and in rural areas and in farms. They are saving government a lot of money in the sense that they are paid very, very little with the so much work that they are doing. And this comes at a very low cost to the government, and they're saving lots of lives in our community. And these are mainly poor women who are coming from poor background. But the experience that they had, the amount of work that they're doing is just too much. So I like the fact that you raise a concern around NHI. Definitely they're going to be affected by NHI in some way, in either way. And it's also quite shocking, the figures that you shared on how skewed our health system is towards the private health sector. Yeah, thank you so much. We're going to open it up for questions now. Comrade Russell, I don't want to waste time in reading all the questions that have been asked. Do you mind touching on a few before?
Not a problem.
Thanks.
Not a problem. I think
Also,
firstly,
if Yvette, feel free also to jump in after Russell before we open to the floor.
I'll start with Shani. Look, Ms. Giffen, thank you very much for your very comprehensive question. I hope I'm not misgendering you. But in short, look, firstly, when we come to leadership, governance, and accountability, we have to start with what are we accountable for? And I think the point that I was trying to make is that in South Africa, we stepped into a moving river, right? When we moved to the democratic dispensation in 1994, we inherited a system, though well developed, was really just designed for a small percentage of the population, right? 10 to 20%, right? So a lot of the assets that we've set up really aren't geared towards expanding access to healthcare for the broader population. By way of example, if we look at the paper on the transformation of healthcare services in South Africa, we found that in those early years, the difference in spending in the former homelands and in provincial administration was almost like 304% more to 400% more in provincial health services than what we did in homeland health. Health is also socially determined, right? So given our inequality and with 80% of the population really living below the breadline, it's also not practical for us to be spending 60% of our money on higher levels of care, which are more utilized by higher LSM, according to Di McIntyre and John Atakuba in their 2018 publication on equity in the South African health system. So when it comes to good governance, I think the important thing for us is really to start giving life to this idea of progressive realization to quality healthcare services. And to do that, we have to improve healthcare services for the people with the least access to care. That's my first question in terms of leadership and governance. So in my view, the NHI is something that addresses that obligation to take legislative and other measures to progressively realize the right to health. Secondly, look, corruption is a risk. It exists everywhere. It existed pre-1994. It's not something that is typically black or started when we had freedom in South Africa. Yes, media reports and so forth indicate that we are in a much bigger crisis than what we may be sometimes. But if we take a moment back, currently we allocate 265 billion rand to healthcare each year, right? Out of that, we fund 400 hospitals, 3,500 clinics. We support the training of medical professionals. We support entities like the Medical Research Council, which typically is also a Schedule 3A entity and has had clean audits, right? And yes, there are examples where this hasn't worked. But if we look on evidence, even when we consider things like irregular and wasteful expenditure, corruption isn't that big of a risk in the health system, but it continues a risk that needs to be managed. Currently, probably 65% of all healthcare spending is on employing staff. A big portion of that is buying consumables. And even based on current Auditor General reports, we don't have significant instances of corruption in the supply chain process. But I do say we need to look at it a little bit more deeply. But we have experience of running a healthcare system. Our health outcomes have improved over the 20 years. It's maybe not a popular thing to say, but maternal mortality is down. Infant survival is up. Increased survival of under fives are up. Vaccination coverage is up. We've literally ended HIV as a public health threat. And on a whole lot of different areas, the health system has actually been quite effective in driving equity, but a lot more needs to be done. But when we talk about leadership and governance, we need to focus on what are we accountable for, whether the mechanisms that we currently have in place are sufficient, and what more needs to be done from a legislative point of view to improve equity. Coincidentally, we spend 265 billion rand on private healthcare. They neither employ healthcare workers, right? The average, the DG of the National Department of Health doesn't earn even above 2.5 million rand. The chief executive at many of the medical scheme companies that don't even cover the full portion earn in excess of 7 million rand, right? To run a medical scheme, which is not responsible, or medical scheme administrator. So I think there's a lot of disconnects in the system. So we need to always focus on what is the problem we're trying to solve. And I think collectively we're growing. And as a community, including fellows from Tucana, we can improve accountability in the system because the current legislative framework, NHI notwithstanding, already allows for community participation at all levels of the health system. It requires more investment and it requires more people to be there. Secondly, in response to Amanda's question, primary healthcare services are likely to include the kind of things called essential services, maternal and child health services, including reproductive health, responses to infectious diseases, responses to non-communicable diseases, which is probably one of our biggest challenges, and which the current system is not well organized to deliver. And I think under the NHI, through the introduction of the integrated private practice, we could have a better response to that. And coincidentally, this level 1 district health services would also likely to be included in that. Where the disease burden comes into play really depends on the health system data at that level. And with the decentralization, there's a greater opportunity to refocus health spending and health priorities to the local level, meaning that we can be more responsive, something which is really very difficult at the moment. Right, on national guidance, yeah, I think basically when the National Health Act was passed in 2002, I'm just looking for the appropriate section. I think the area that in some ways creates all the mess legally under Chapter 1 of the National Health Act, I think the most important area that requires clarification is, and again, just bear with me for a moment, I'm sorry if I'm taking up too much time, is Section 3 of Chapter 1, right? Where the minister is required to declare, all right? At Section 3 of Chapter 1 of the National Health Act, under the responsibilities for health, right? Subsection 4, subsection 1, D and E, right? Ensure that the population, the provision of essential health services, which must include primary healthcare services to the population of the Republic, may be prescribed after consultation with the National Health Council. That provision hasn't, at March 2019, has never been declared. And I think that creates a bit of a mess. Neither does the minister provide any guidance on the prioritization of which healthcare services, right, should be delivered publicly. And I think all of these gaps lead to us all coming in, having our own interpretations. And at the end of the day, we're not investing enough money on the people that need the greatest access. Thank you, and over. I hope I answered the question in some way.
Thanks, Comrade Russell. Thank you so much. There's one that speaks on the NHI, will it address climate change? At this stage, we are not sure about that. Oh, okay, Yvette is going to answer that. Okay, Comrade Yvette, you can go ahead and pick and respond to the questions that you have picked up.
Thank you. On the issue of climate change as an emergency in health, I think Comrade Russell did begin to answer that by saying there will be, the NHI will seek to address the basic essential services. And I think it may be province dependent. I think where the provincial department is aware of the crisis of environmental health, hopefully that will be included within that. So for example, in the province of KwaZulu-Natal, one would hope that the Provincial Department of Health begins to look at the impact that environmental health is having on, or the environmental crisis is having on the implementation of basic primary health care services. And I think there was another question where a fellow was asking about how can we as fellows and advocates ensure the implementation of NHI. And I think that in our role as fellows, we have an important role to play in understanding where we are based, what the local health system looks like in the areas where we are based, beginning to know what services are available, what ideas are beginning to filtrate through as with regards to how people are thinking and feeling about the implementation of NHI, but also about the district health services, because slowly the district health services are beginning to be changed and shifted to accommodate the NHI, which we see coming down the road. So, for example, here in the Western Cape, we have a plan called Healthcare 2030, which looks at community responsive healthcare services within the district health system. So it's about knowing what system you are functioning within and how you can begin to support, motivate for change, get involved with the system in your local area, and then begin to bring about change and influence where you can. I know that currently within the Western Cape, we are creating spaces called wellness hubs, which look at the first level of primary health care. So provision of primary health care in non-healthcare facilities, so that people with need for support around their diseases can be seen in community spaces rather than in a clinic, which allows the sickest of the sick to be seen in the clinic, and then for people to get support with regards to living with their chronic diseases, to get that support in the communities where they're based. Also, the wellness hubs are available, like are open at times which are different from the healthcare facilities, which makes it more accessible to people who have to go to work, to moms, to school-going children, etc. So, for example, we people in the Western Cape can begin to motivate for more wellness hubs, for a generalized package of care, for better working conditions, better salaries for community health workers, because I think Comrade Tinashe mentioned that at the moment, the community health workers are almost the backbone of our healthcare system, and yet they're not paid what they should be. They're not protected by being, well, in the Western Cape, they're not protected by being incorporated into the health system. They are employed on a contract basis via funding to the NPOs. And so there's no security for the work that they do, and yet we know they are the backbone of our health system. And as the pressures increase on the health system, the pressure increases on the demands that the health department makes on community health workers. So how can you as advocates and fellows, how can we kind of come together in a collaborative effort? And I think this webinar series is maybe the first of that, for us to start to say, well, what are the needs? What are the pressing issues? And wherever you are based, what can you do to begin to address those things and support and really start to take an active role? Because as we say in the Western Cape, health is everybody's business, and it's not just the business of the nurses or the doctors or even the politicians. It really is everybody's business. At some point, all of us will need to access healthcare if we haven't already. And therefore, we need to start taking responsibility to ensure that NHI is implemented in a way which does allow for the best access of care for the most South Africans possible. I hope that answered those two questions.
Okay, thank you so much, comrades. It's been quite a good, robust discussion. Unfortunately, because of time, I just want to know if there are any two hands that I can give to just ask questions. Only two questions. I will first come, first serve. Please raise your hands. Only two questions from the floor, and then we're gonna close it up. Sorry that we are running over a bit of time. Any last two questions? Any last two hands?
I'm happy to make a closing comment if there are no questions.
Okay, there's one. Can we just save one from, is it Michelle? Rene, can you allow Michelle to speak?
I've got Michelle's question. I've read Michelle's question.
I have unmuted. Thanks,
All right.
Sorry, Russell.
Thanks, Russell. If you've read my question, then perfect. You can just answer. Thanks so much. Thanks, everyone.
How can fellows get involved? Right. Firstly, I think obviously join us, right, in our conversations around equity in the health system. I think the first thing is that firstly, read the National Health Act. Right? Read the National Health Act. There are provisions in the Health Act that allows for participation at all levels of the health system. We can make representations to the National Health Council, but we are not represented there. All provinces, including the Western Cape, have not established provincial health councils to oversee the ministry. All right. And I think one of the areas where fellows can really add a lot of value is really asking for greater accountability at the provincial level in the absence of provincial health councils. Thirdly, at the district health level, Chapter 5 of the National Health Act deals with district health councils, which allows for the participation of communities in the oversight, design, and evaluation of healthcare services. These things have been underdeveloped. We need more than just us activists working in that space. We need a lot of your skills to also begin to participate in calling for greater accountability at all levels of the health system and to ensure that healthcare services are responsive to the needs of the population where they are. And I think lastly, we have to use whatever spaces that we have to allow for cross-learning. South Africa is a unitary state. Provinces are not independent. They exist to implement national health policy. And I think if we are areas where some do well, we should really start encouraging cross-learning between districts and between provinces, rather than all building our own little stalls at the market. And I think my last comment is something that all of us activists, advocates, and fellows should really start helping us build more knowledge on, is the separation between the institution of state, which is the thing that is permanent, the Department of Health, at a provincial or at the national level, from the government, which is the thing that is transient. We're going to elect a government now and we can replace them every 5 years. But we need to work harder on addressing the conflation between government and state, and work harder to strengthen the institution of state. The NHI and health in general can't improve without careful consideration of improving governance at all levels. Thank you so much. Over.
On that note, comrade, thank you so much. That's a good closing remark, that we really need to get involved and start holding accountable of our provincial health department. I'm going to give it to Comrade Asina for the closing remarks to just wrap it up. Thank you so much, comrades, for attending.
Hi, everybody. I'm driving as always, so it's my standard picture on Zoom. Thank you so much for the participation today, and to Russell, Yvette, Tinashe for making this possible, Rene and Bernard for your background work and efforts. In closing this up, I just wanted to say that NHI has been such a contentious issue for us in the healthcare sector, in the advocacy sector, in the equity sector. And what has come about from this is that we've really started to understand that each of us in our own personal capacities, we have no idea where we are at in terms of NHI. What does it mean for us as a person? And when we start at the individual level and start to make sense of it, we realize that as much as it's going to impact us, we have a bigger role to play in making sure that the impact we feel is managed by us through our actions, right? And I think that what stands out for me is that we keep speaking about national, provincial, and district levels. We speak about mandates that come from national, and if they are not actioned by the Department of Health and who's tasked to hold them responsible, we each have that ability and that power and that capacity to hold people accountable. And that accountability comes from us in our individual capacity, but it also comes together from us in our sectoral capacity. The NHI as it stands, and health as it stands as a right in the Constitution, is not a standalone entity. Health is dependent on the different pillars on which the country stands, and that includes your economy, your roads and infrastructure, your sewage, your water and sanitation, and each of us work in those spaces, and we can influence change directly, even if it's in a small way within our office space, and then build onto a larger community. I think that this discussion about what NHI is, how are we going to pay for it, who will be taxed for it, where is this money coming from, directly takes the question back to, do we have the capacity at an individual disposable household income level, and then to the national fiscus, to be able to afford this? And this is the question that we're going to lead toward in the next webinar. And we're going to try and create pockets of discussion in between. Please do join us for the next one. And once again, thank you so much for participating. We look forward to the sectoral discussion that's coming up in the next webinar, and then our in-person gatherings in Gauteng and Cape Town. Thank you, everyone.
Thank you. Bye.
Thank you. Bye-bye.
Goodbye. Thanks, everyone.
Bye-bye. Thank you.